This conference will now be recorded.
Hi, everybody, and welcome to the AnCan High Risk Recurrent Advanced Prostate Cancer video chat for Monday, April 15, 2024. I hope you did your taxes. I'm Len Sierra. I'll be moderating today with a little help from my fellow moderators and everyone present here. We want to thank and acknowledge our sponsors, Bayer, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. Anybody I missed? Okay. Let's go with uh, Steve. Steve Skogland, you are new. Steve, I'm going to go through a questionnaire and ask you a few questions.
All right.
And how old are you, Steve?
I'm 58.
58. And so you heard about AnCan and you contacted Peter, and then Peter gave us a heads up that you'll be joining.
Yeah,
So how did you find out about AnCan? I assume it was before Peter?
yeah, it was before Peter. And to be honest with you, I've been dealing with this by myself, this prostate cancer journey. And all of a sudden, you guys just popped up one day, and I got hooked. And I probably watched like 60 episodes of you guys. And I just says, this is a place where I need to be.
Okay, you did your homework.
I did.
Um, Steve, how old were you when you were diagnosed?
So I was quite young. I was 52.
Okay, and do you recall your Gleason score and PSA at that time?
Yeah, so I went in for a physical, and my doctor just says, you want me to check your prostate? Of course, didn't even know what a prostate was. And he says, yeah, I feel a nodule. You better go have it checked out. So I went and had my PSA tested, and it came back at 15.3. So after that, they did a biopsy, MRI biopsy, and they took 14 cores, 9 were positive. Um, I had a couple that were 4+4s, quite a few 7+4s, and then a few 3+3s.
Oh, it sounds like 4+4 is your highest score, Gleason 8.
Yes, correct.
All right, and where were you being seen and by whom?
At that time,
Yeah.
so I was seen by, uh,
Well, let me put it this way. At the time of your first treatment, who were you seeing?
so so that would have been Dr. Guadamaja,
And what institution?
the University of Minnesota.
Okay. And you were still 52?
Yes, correct.
And was this doctor a urologist or a medical oncologist or radiation?
Yeah, so this guy's a medical oncologist, hematological oncology and internal medicine.
Right. So, what was the recommendation for your primary treatment?
So based on the findings, since I was young and it did break through the capsule and it invaded the right semi-vesicle. So they recommended to me to just throw the kitchen sink at it. They told me to take my prostate out, which I did. And then I had 40 treatments of radiation. That was to the pelvis and the lymph nodes. Well, I guess the pelvis area is what they're saying here.
Yeah.
40. And then I went on 2 years of hormone therapy, Lupron alone.
What therapy was it? Lupron?
Yes.
Okay. Any other Any other hormonal therapy? Just Lupron?
So since 2018, I have had no other drug than Lupron. That's all that's ever been given to me.
Okay, so you had a radical prostatectomy, you had whole pelvic region radiation, including prostate probably, and 2 years of Lupron, and that brings us up to what year?
That brings us up to 2020.
2020. Okay, and what's going on? Oh, so what was your PSA at that time? How had you responded to the treatments?
So I responded good to Lupron. So it went undetectable for about a year. Well, actually, after the surgery, it was probably 2 years. It went pretty much undetectable, and then once I came off of it, my PSA started to rise pretty quickly. It started to double in a month, each month.
Hmm.
And
And so that was in 2020. It started doubling every month.
yes,
Okay, so what happened next?
so then they put me back on Lupron again.
Right.
This one, he wanted me to go into a trial. So I elected to do it because I thought it'd be a good thing. But the trial was AFT 19. I don't know if you ever heard of it.
I haven't. Anybody know of AFT 19?
So basically, it was a 3-arm clinical trial. So one was with Lupron alone. The other trial was a combination with apalutamide and prednisone, I guess is what they call it. So it's kind of like a dual treatment, but I didn't get that arm. I only got the Lupron arm. So
Okay. So in other words, just continuation of what you were already doing.
yeah, and that was kind of just like, geez, really? Is that really, I really didn't know. I just went along with it.
All right. How long were you in the trial?
So I guess I had to do it for 1 year. So I completed that. I did 1 year of Lupron, and I completed that in March of 2023.
How did we get from 2020 to March of 2023 after a 1 year clinical trial? Did I miss something?
Well, when I had my first PSA relapse, that's when I went back on Lupron. And that was,
Okay. So we're up to March 2023. You finished the clinical trial, and where is your PSA?
so my last PSA, my last shot was in March of 2023, and I just relapsed again here back in October, and it started doubling once again every month. It went
So you're
from
on a drug holiday from March to October of 2023. Is that right?
correct, yes.
Okay. And then in October, it started doubling in a month. And then what did they do?
So they wanted to put me back on Lupron once again. I said, well, shouldn't I have a PSA? So I had 2 PSMA scans through this whole process. The first one was when I first relapsed. I went through the PSMA uh, imaging, and then when I relapsed again here in 2023, I says, I'd like to have another scan. And the doctor just kept on saying, well, it ain't going to show anything because it isn't high enough, and odds are we won't find anything. So I just persisted. I says, I want one. So I got one, and it came up clear. There was no metastasis anywhere. Everything was clean. My PSA was at 0.87 when I got that scan.
And you were on Lupron at the time or not?
No.
Okay. All right. So your PSA is 0.87. Your scan is clean. So what happened next?
So I'm back on Lupron.
Okay. I'm guessing that your medical oncologist is not a GU medical oncology specialist. Do you know what that is?
Yeah, so after listening to quite a few of your guys' webinars, I've kind of figured out that that's kind of the doctor I need. And then when I heard Peter's doctor here, he goes to the University of Minnesota, and the doctor he sees in the same clinic that I have my doctor with, and I figure I need to go see him.
That was Antonakis, is that right?
Yes, correct.
So have you seen him yet?
No, because I called and asked if I could have an appointment with him, and they says, "Well, we got to go through this. We got to go through a whole bunch of chain of command, supervisor, to see if we can get you switched." And I says, "Well, that's what I really want to do." So I haven't heard back yet whether they'll let me do it.
Hmm. What about genetic testing, germline or inherited uh, gene testing? Did you have that done?
Yeah, so I just sent it in. I sent it in. Color just got back to me, said they received it, and they'll call me with the results. So I got that part done.
Okay. What about somatic testing, genome testing on the tumor tissue itself?
No, and that's another thing I learned from you guys. So that's another thing I want to get done. And I talked to Peter about that too, and they should still have it, I'm assuming, after 6 years. So
Okay. So Rick is asking what your current medical oncologist, is he a GU specialist or no?
no.
Okay. All right. Is there anything we left out or haven't covered in your journey?
No, I guess other than I've had my prostate removed, I had radiation. My only treatment's been Lupron. I've relapsed twice now. Every
Right.
time I relapse, my PSA just skyrockets. I mean, it's like crazy. So I know it's pretty aggressive cancer, but it's responding to Lupron. My last PSA, I get another one tomorrow, but the last one was 0.9. That was in January.
Well, while you're waiting to get switched over to Antonakis, and I certainly hope they allow you to do that because I know they typically don't like patients to switch within the same group from one doc to another, but in this case, it's pretty clear you need a GU specialist, so I hope that goes through. But meanwhile, um, maybe you need to talk to your current doctor about getting a second line anti-androgen. Do you know what I mean by that?
Yeah, so I asked him. I sent him a message in my chart saying, I would assume that he would have brought that up, but he never did. So I'm the one asking these questions like, am I really the doctor here or are you?
It's a good question.
So I asked him, I says, shouldn't I be on a double treatment, just not Lupron alone? I feel like I'm being left out or losing some valuable, you know, time that I'm wasting here if it's going to spread.
Yeah.
But that's
So
him
what did
now.
he say to that?
He really never got back to me, so that's why I think I need to get somebody else.
Okay. Well, I hope they move quickly on that. I don't know, Peter, is there anybody he can speak to there who might move things along?
Well, my question is it appropriate for me to contact Antonakis and bring this up, bring this name up? I can do that on my chart thing. Yeah, I don't know how they work internally there, whether they're going to get upset, with the request to change doctors. But I can certainly put a word. I can try to put a word in for him. I won't see Antonakis himself for another 6 weeks or so. Um,
Yeah, I think
but I could,
it's fair to, if you're able to message Antonakis, I think it's fair to say that Steve is not getting standard of care. It's pretty
that's
obvious.
what that was my take initially too. That
Yeah.
he's not getting it. No, and even probably the trial was not appropriate either because he was on the short straw. You know,
Yeah.
you know.
So my
Oh, I
question,
guess no
could
need to mention that though. That's
No, I
history
won't
now,
bring
right?
that up. Yeah,
Yeah.
that's history. But he's
so
still on it. He's still on the short straw
Yeah. Yeah.
with
that's
the
what I
same
thought.
doctor.
I have a question though. So this ATF 19 trial. So I completed the Lupron, but now I have to follow up with these scans every 6 months, bone scan, CT scan of the pelvis, and I need to do these every 6 months. Does this trial like go on until I relapse? Is that what the thing? Is that what the goal is with this? I think that's what this trial is, to go till you relapse, I guess.
Yeah. I think you should just get out of the trial.
That's what I'm saying. I mean, I just had a PSMA PET scan in January. Didn't show anything. Now it's going to be May. They're going to do just a regular CT bone scan. I don't think
Well, what
that's.
they're Steve, what they're looking for is um, lesions that may not be PSMA positive. So they'll be picked up by other scan techniques. It's just kind of a CYA, cover your ass, make sure that you don't have any non-PSMA lesions that are active and growing.
So keep going with it.
But yeah, actually, yeah, I think it might not be a bad idea. While you're waiting to get over to Antanaracas, if they want to give you these are free scans for you, I guess, right?
Well, I thought clinical trials were free, but they're not. I mean, they still charge my insurance company. So
Oh, well, okay, but you're not charging you, I hope.
no, no, they
Yeah.
charge my insurance company. I just pay, the copay or whatever my deductible
When,
is.
when is your next scan scheduled?
Next scan is May 9th.
May 9th. All right. Why don't you keep that on your calendar? And meanwhile, if you get switched over to Antanaracas, you could always back out. I don't know.
So
Anybody have a better idea?
yeah, I just really don't think I'm getting the standard of care that, I mean, I've been listening to you guys and it just seems like I'm just getting the short end of the stick here with just one treatment my whole 6 years with this.
Yeah. Yes,
At
you are
point
correct.
nine, he should be getting abiraterone or enzalutamide immediately. He should have been getting it a year ago or 2 years ago. And if he can't get an answer to antacids right away, he should go somewhere else and find is there another GU oncologist in the area he could go to? Because he's just being mistreated so badly, it's absurd. This guy, they're trying to kill him, it sounds like.
Well, I would keep after them, Steve. Whoever it is you're dealing with at U Minnesota, just keep after them. Say, look, I really feel like I'm not getting proper care. I want to get switched over to Antanaracas ASAP. Make a pest of yourself.
Yeah, that's what I'm going to do for sure, because something really does have to change before it's too late. And I got an opportunity right now. Well, I don't have any metastasis and I'm responding to Lupron very well right now. And I just don't want to give it up to where it's too late.
Point 9 is not responding well to Lupron. Point 9 means that Lupron may not be working for you anymore, and you should have been on something else as well.
No, it's 0.09.
You said 0.9. Okay, that's different.
Oh, yeah, that changes things quite a bit. That decimal point is very important, Steve, because that makes sense that your PSMA scan would show nothing if you were at 0.09 PSA when they did it.
Yeah, I thought I said that. I must have screwed you guys up.
Well, you said 0.9 or 0.87, I think you said. But anyway, um, yeah, everything we said still holds true, except the fact that they're scheduled. Now I am not so sure it's a good idea to go through with these non-PSMA scans. because your PSA is so low. It's unlikely to come up with anything. Just focus on getting over to Antanaracus. Anybody want to talk to Steve besides me? Go ahead, Alan Babcock.
Yeah, so if you call up there and they start hassling you, I would quickly say, okay, to whom can I appeal this decision? And if they continue to hassle you, you say, all right, tell me how I can file a complaint because I don't think I've gotten good treatment here. Do I go to the MAA, Medical Association? That usually gets people's attention. It always got my attention if somebody asks me that. You
It's a
might
good
have to be
idea.
really assertive.
Eric?
Yeah, I just
Yep.
I just have a question. So, if he had his prostate removed and he's still generating PSA, doesn't that still mean that there's prostate cancer somewhere?
Yes.
Okay, so it was localized in the prostate. He had it removed, so it's somewhere else in the body.
Correct.
Okay, so
It had already gone to the seminal vesicles, though, so the cat was out of the bag right
oh,
from the
okay.
get-go.
Hey,
All right,
Steve,
Steve.
did you
Any
get
other
any
questions?
hormone therapy?
Did I get any hormone therapy? Is that what you asked?
Yes.
Yeah, the only treatment I've ever had is Lupron.
So, Steve, any other questions for us? We have so many new guys we have to go through. I'd like to move on if we can.
No, I think you guys move on. Like I said, I think the doctor is my next step. I have to get somebody else.
Yeah.
I'll send Antonakis a note in the my chart thing.
Okay, and I'll keep you updated if they get back to me anytime soon. I'll keep you in the loop. Thanks, guys.
Thanks, Steve. I'll see you in June.
Yeah, I can't wait.
Okay. Let's see. Jeff Steinberger, you're also new. Are you ready?
Hey,
Okay. So you
I,
see how this works. So I'll go through the
yeah,
same
I
set of.
see how it works.
Yeah.
Go
So
ahead. See how it works.
Jeff, how old are you?
75.
Okay. And when were you first diagnosed?
I think I was diagnosed in 22.
Okay. And you recall your original Gleason score and PSA at the time of diagnosis?
Yep. 443, Gleason 7. And my PSA was about 7.0.
Okay. Uh, where were you being seen? Where did you get your first
UCLA.
primary treatment?
Well, I got my biopsy at Sloan Kettering in New York.
Okay.
And I had 20 IMRT treatments at UCLA with Keyshawn.
Oh, you went all the way across the country. Why didn't you have it done at Sloan
Yeah.
Kettering? Just curious.
Why did I have the biopsy there? Because the doc who was doing the biopsy was the only one that could do a transperineal. And UCLA, as big as it is, still doesn't have transperineal biopsies.
Oh, okay. So you live in California,
I live
should
in
have asked.
both California.
California and New York?
Correct.
Yeah. All right. Okay, so you had IMRT, how many sessions?
20. 20.
20, right. Hypofractionation there. And
Right.
Did they put you on hormone therapy at the same time?
Unfortunately, 4 months.
4 months. Okay.
Correct.
And what happened after that? How did you respond?
Uh, the radiation treatment worked terrific. I think it's great. My PSA in last December was 0.14. I stopped Orgovix in May 30th of 23. And then in I stopped Orgovix in May of 23. The radiation seems to be working fine. My problem is testosterone. My baseline was 286 before I started with any treatment. And it's been now, I ended Orgovix May 30th, and my testosterone has only gone up to 98. And I have a 34-year-old wife, and my libido is gone. And I have a Sophie's Choice, which I can't get a correct answer on. So maybe you guys can help me. It's regarding whether to start TRT or wait for my own testosterone to come back. It came back from 78 to 96 in December, and that's the highest it's been. My understanding of TRT is that the Sophie's Choice is if I start taking TRT and I end up having side effects from TRT, AFib, tachycardia, whatever it is that I can't deal with, I'm closed out from what I'm understanding. I am closed out from waiting for my own testosterone to come back. So if I take the exogenous testosterone, my oncologist says you have no problem, but there is a problem because if I have side effects and those side effects are pretty horrendous, like AFib or other stuff, and I want to stop testosterone, the TRT, my pituitary gland and my testicles are no longer producing it if I've been on it and that's the problem. I don't know if is there a end date? If I've been on it less for a month, will my testicles still produce testosterone, or if I'm shut out completely after a month or 2 months on TRT? I have started at 78 once I stopped Orgovix. It was at 78. It's now progressed maybe in 6 months, 7 months to 78. Maybe I got 20 points. No, I'm really at 90. I'm sorry, 90. So I'm still
Jeff, let
hypogonadal.
me ask you, did you say, what is your current PSA? Is it undetectable? I thought I heard you say 0.14.
Yeah, it is. It's 0.14.
Okay, so you still have some cancer.
Radiation, sorry. Yeah, but I have radiation treatment. So I still have a prostate.
You still have a prostate. What did they do?
Right.
They just radiated the prostate gland, nothing else?
They radiated the prostate gland, period. 20
Okay.
radiation treatment. So they know that I'm going to have a 0.1, 0.2. That's normal for radiation. It's not normal for the surgery, but it's normal for radiation to be running that low.
Well, what about some of our MDs here? Dr. Jeff, Dr. Jack, you want to comment on the testosterone replacement therapy?
Has your doctor discussed the risk of taking testosterone uh,
I'll give you
while
I'll give
while
you
you're
the
still?
exact.
Yeah, go ahead.
Uh, my oncologist, well-known oncologist, said, "I guarantee you that you won't have a recurrence." Says, "I've treated all these testosterone replacements, and your situation doesn't look like you're going to have a recurrence." And that's one of my concerns as well, is obviously the recurrence. And I know they want me to get NED to get as low as possible with my PSA so that they feel confident in it, but not one of them will, except for my own oncologist, who's a little optimistic, obviously, guaranteeing that I will not have a reoccurrence from the testosterone. Keyshawn at UCLA said he would okay it to take it back up to my baseline, which was 286, and he doesn't think that I will have a problem with that as long as I don't go higher. And my other oncologist at Cedars-Sinai said that the same thing. If I take it up to 286, your baseline, you should be fine. And I was fine at 286 at my baseline, so I'm thrilled if I get it there. My problem is, do I wait for it naturally? It's been now 10 months since I've stopped, and it's not gone. It's gone to 90. It was at 40. And it's not moving. And I'm getting older. And my wife is getting older and a little fed up. So
And
that's
is
where I
that
am. And
testosterone that you have a total testosterone or you have free testosterone?
no, that's total NG, whatever.
Yeah. So yeah, routinely the test that's done is to measure total, but I think your free testosterone is a more accurate measurement of your uh, physiological activity of your
No, I'm
testosterone.
sorry. The total is where 500 is normal, correct? 3 to 500 is normal on the total.
Yeah, more or less.
Okay, so then it's total. It's not free.
Yeah, you
My
should ask.
100 is
Yeah,
total testosterone.
you should ask them next time you get your blood. You should ask them to do not just total, but also free.
They did free. Free 0.1.
No,
No, it's not zero. Not testosterone 0.1. No, see, no. I don't know what the testosterone free was. I know what the total was. TSA testosterone 90 in December.
what time did you have that drawn? What time of the day?
About 12 o'clock. So
Try to
my
do.
oncologist also. I'm sorry, I don't see who's talking.
Yeah, I was going
He
to
doesn't
say,
have his video on.
try to get it
Oh,
done
okay.
at 8 o'clock in the morning if you can.
I will. I know the variations in the up and the down cycle, and they said that the up and down cycle to my age doesn't really play well. They think it's the same whether I take it at 1 or whether I take it. It's not going to be that much of a discrepancy. My free testosterone was 14.6. So what I'm curious about is, do I jump in and take TRT? It's been 9 months since I stopped. It doesn't look like my testosterone is going to be jumping from 98 to 286. And what do I risk when I take the TRT? Because I want to start living my life. And so does my wife.
Peter
And
Koska, you had a comment or question?
Yeah. So I don't know who your medical oncologist is. One of my medical oncologists is Dr. Schultz, a prostate oncology specialist in Marina Del Rey. He
That's my
works,
oncologist.
huh?
That's
That
my
is your,
oncologist.
okay.
Yes, sir.
He's pretty familiar in this field, and he's willing to take risks with you. And he suggests this to me. I'm probably in the same boat as you. Mine floats around between 70 and 90. I'm about the same age, maybe a year older than you. Yeah, mine's not going to come back naturally. I've been hoping it would, but it's not going up into the 200s or 300 range anymore.
How long have you, Peter? How long have you been waiting for it to come back?
Well over a year. Well over a year. So it's not going to, I don't think mine's not going to come back. It used to come back. I've been in this game for 10 years. It used to come back, but not anymore. And maybe it's age or whatever. Schultz suggested I go on testosterone. I have another oncologist who thinks differently, so I'm not going back on it right now. I don't have a 35-year-old girlfriend right now. My girlfriend's willing to be patient with me because she's even a little bit older than me. So I'm okay with that, but I understand your situation. And if I was in your shoes, I might take the risk and try it. I mean, as long as you have a doctor that's willing to follow you carefully and monitor this and watch you for other odd things that might go on, like AFib and this and that. If it was me, I might take the risk.
Let me ask you. So that's the question. If I take it and I go on it for a month, can I go back to, if I start having like AFib or some serious side effect, can I go back to natural testosterone and waiting again, or am I cut off because my pituitary gland and my testicles have already had the exogenous, and that's going to prohibit me?
I don't have the answer to that, but Dr. Schultz should. He should know that kind of stuff because he's been in this game a long time, many years, and he has a lot of guys in your kind of situation.
I know, but he doesn't have the answer to that one.
Jump in there.
Me? I have a question for you, Jeffrey. How old are you?
75.
How old are you? Sorry?
75.
If you're 75 and you are on Orgovix, which you might know has a profile that features faster return of testosterone typically than injections do. If it's been over a year and you're 75 years old and it's only come back to where it has, ask, of course, Dr. Schultz, but the chances are that you're going to be waiting longer than you want to, and it may not return as much as you want to. But my question for you is, if Schultz assures you that you're not going to get return of cancer by taking TRT, and you want to take it, but you're concerned about AFib and other side effects, you might think about whether you're just getting ahead of yourself. And if you want to do it, it's your decision. If he wants to support you in that decision and you have a 35-year-old wife, we understand how you feel. If you take it yourself, your question is, if I take it for a short time and get off of it, is it going to mean my body is completely shut down from returning on its own? Well, it sounds like it's pretty much shut down from returning on its own now, so you may never know. But as far as it being worth a risk, if I were in your place, I would certainly be considering it strongly, considering you are on Orgovix, you're 71 years old, you have a young wife, and these side effects of AFib and everything else that might come from being on it for a short time would certainly abate if you stopped it. So it's not, I'm not telling you that I think you should do it. I'm not.
The only problem is if I stopped it, but then I can't go back. So if I stopped it, I'm living with a 98 testosterone.
Of course you can go back.
I'm hypogonadal.
You can always go back to TRT.
For the rest of my life.
You can go back to TRT. If you take it and you stop it and you do it again, you can take it. It's your natural testosterone that may not return. The artificial, not artificial, but the supplemental testosterone, you could take that again. You should ask Dr. Schultz about all this. I mean, he's a very forward thinking on that particular. I would say forward thinking. He's very, as you know, and as Peter told you, he's supportive of this in general. So you know, you're lucky or unlucky there, depending on how you think about it. But you know, I think you're worried a little bit too much about what might happen, and you're never going to know. You wait for it to come back now, and you're 71 and you are on Orgovix. I can just tell you that your odds are not good if you're getting a good return now, but yeah, you could wait another 6 months or a year. But I can understand your antsy. That's all I have to say.
So my concern is that I went from 70 in December to 98. So I had a 25% leap, call it a leap, in the testosterone. If I work out, lose weight, have the natural process work, I may come back to 150 where my libido will come back and I'll be happy.
Have you been doing that? Let me ask you a very important question.
Yes.
Have you been doing that? You say work out, lose weight. Have you been doing those things, or are you planning to do those things?
Yeah. No, I'm doing it now. I'm in walking 4.5 hours a day. I'm on a bike for an hour a day. I'm making an all-out effort so that I get this testosterone back.
If you want to have good sex with your young wife, you're going to need plenty of exercise,
Yes.
my friend.
Yeah.
All right, Jeff, you know, we've got another new guy we've got to go through. We can go round and round in circles here. What Ginny said is true. This is a decision you have to make. You have to assess your risks and your desire to have your T levels come back. Dr. Schultz is more of an expert than we are here. So I think we can't help you more than we've already tried to do. Okay? It's all right if I move on?
Yeah, sure.
All right.
So thank you.
Thank you. Adam Alvarado, are you still with us?
Yes, sir.
There you are. Okay. So Adam, how old are you?
I am 49.
49. Okay. And when were you diagnosed?
I was diagnosed on Memorial Day of last year.
Okay. And what was your Gleason score and PSA at that time?
My PSA was 570, and my Gleason was 4 + 5, 9.
Okay. And have you received any treatment? I assume you have.
Yes. Yeah.
What did you? Where are you being treated, and by whom?
Sure. My urologist is Dr. Carlos Ramos here in Panama City. My oncologist, well, I switched on medical oncologist. The medical oncologist started out as Dr. Haberman, and now I've switched to Dr. DeLeon, who's in Miramar Beach, but Dr. Haberman is with Florida Cancer Affiliates in Panama City. Also am seeing Dr. Finkelstein as a radiation oncologist. You asked about treatments. I started off on Erlita and Degarelix. And then we also had my 6 treatments of Taxotere, docetaxel. The last treatment I had of the Taxotere was January 11th. I switched in, I think it was January, may have been October, from Degarelix because I had such a good response with just the first and second generation. We switched to Eligard and Xgeva. I've been doing Xgeva. I did monthly Xgevas for 7 months, and now I'm doing the Eligard every 3 months and the Xgeva every 3 months. So.
Okay. Tell me have you had a PSMA PET scan or MRI or CT? Tell us what you have and what it showed.
Yep. No, I've had all of those. I've had 2 PSMA PETs. I had a PSMA PET about a week and a half after diagnosis. That showed widespread. I'm trying to remember all the stuff. It didn't go into all the details because it was widespread. I've seen that. Went up to MSK and had a second opinion. She showed me the scans, but it was spread to primarily lymph nodes in the chest, neck, abdomen, pelvis, as well as at that point they pointed out a spot on my T8 vertebrae and something in my pelvis. And then my second PSMA PET, because I was considering and still am considering lutetium. The SUV uptake values for that first PSMA PET were all pretty high. Sorry, I'm just trying to look at it. Like in 28, 15, 19, 18. I said I had a handful of METs in the bones, but it really only pointed out those 2. The latest PSMA PET, which was after about a month or so after the last chemo, was a lot better. It's the max SUV uptake I've got is 6.711. It says most of the lymph nodes have gone back to regular size. It points out a couple that I still have, but it's a much clearer PSMA PET than I had before.
That sounds good. So you mentioned you had Erlita and Degarelix, and then they switched you to Eligard, and you had docetaxel. Any surgery or radiation?
No surgery. Right now I'm kind of at a crossroads and kind of the Reluctant Brotherhood kind of referred me to you guys. Trying to decide. I'm kind of leaning away from lutetium-177, although I do have an appointment with the doctor in Pensacola to discuss that as an option. I kind of personally think my SUV uptake is a little bit too low to be a valid candidate for that. But my radiological oncologist, Dr. Finkelstein, who says he's headed up a couple of the he actually headed up one of the lutetium-177 trials. So he says he wants me to talk to them, but I'm debating focused radiation to focus on the prostate and the 1 or 2 lymph nodes that are still aren't normal in the pelvis or abdomen.
So where do you live, Adam?
I live in Santa Rosa Beach, Florida, so it's in between Destin and Panama City.
All right. You mentioned MSK. You've been treated up there?
I haven't been treated. I went there for a second opinion. I saw Dr. Slovin up there, and she agreed with everything that Dr. Haberman at the time was recommending, which is just the 3 treatment standard of care, so the 6 treatments of docetaxel. And then I might go up there and see her again, just based off of once I finish talking to all the different docs to figure out kind of what I'm going to do next.
What about genetic testing? Have you had any done?
Yeah, I had germline. Germline was negative.
Okay.
Have not done the other one just because they want to save it for, as things fail to get closer to, since insurance won't pay for Provenge or, some of the other stuff that's more specific that the other DNA or other, DNA testing or genetic testing would help out with.
Wow. I would have thought that, I think pretty sure it's standard of care to get somatic genome testing for someone with a Gleason 9, you're high risk, you had metastases.
Yeah, I would have liked it.
Yeah, I would. I don't know. I think if it were me, I'd be pushing for that.
Was
any cancer in your family on either side?
Yeah, not immediate, but like my grandfather, my my maternal grandfather passed away from cancer. Unsure of what he had. The death certificate says lung cancer, but that could have just been metastasized to the lung from somewhere else. My paternal grandmother, who's 93, she had breast cancer when she was in her 40s or 50s, and then she had colon cancer at about 89. But she's fine.
But your mom and dad, brothers, sisters,
They're
nothing?
fine. But I also a Navy vet, so may have had something to do with something there.
Yeah. Do you have any questions for us? Any specific questions?
Yeah. So I guess my specific question. So like I said, I have had a very good response to the medication, to the Erleada and Eligard. I don't really give a lot of credit to the chemo because I did a CT scan with contrast as a baseline before chemo, and then I did one after the fourth, and they said it was stable. There was no change in it, but my PSA as of last check, or the last result I got, which was in January, was 0.04. I just took another PSA test on Wednesday of last week. I just haven't gotten the results yet. But my question is, okay, so I'm at this point. My radiological oncologist, Dr. Finkelstein, is supportive of me being aggressive just because I'm young, and just trying to, while I've got the cancer on the run, trying to take some players out of the field of play, like the prostate and the couple of lymph nodes with radiation. My medical oncologist, Dr. DeLeon, is supportive of what I want to do. He is more conservative. He is more of a, hey, let's try to get you on a holiday in July, which would be the next time I'm up for a round of shots, and then kind of see what happens there, and then just try to do this, whack-a-mole until I get resistant. But I guess my question would be, why shouldn't I do radiation?
I think we would probably agree here that the primary should be treated, whether it's surgery or radiation. In your case, probably radiation better than surgery. Anybody in our group doesn't agree with that? Yeah, I think the answer to your question is what you said. Why shouldn't I? We think you should.
Right. Yeah. That's what I was looking for, a reason not to. I mean, and would you agree that I don't think I'm a good candidate for a Pluvicto or lutetium-177 just
Well, not
based
yet.
on that. Say again? Not yet.
Certainly not yet.
Yeah.
I think you wouldn't even be eligible because you're not castrate resistant. You're still hormone sensitive.
Right.
Yeah. Let's see. We got a couple of hands raised. Jim Marshall and then Peter Kafka.
Adam, you should check out the veterans group that happens to meet here. Okay?
Will do.
Look
Thank you.
into it seriously. I run it.
Okay.
Do we have your email or not?
It's just my first and last name at Gmail. I don't think we have it.
With a period or without a period?
Without a period, altogether one word.
Okay, well, we'll get you. We need the emails from all the new guys, Lynn. And
Yeah.
or please put them in the chat window, or I have yours, Adam. You'll get a reminder for the vet. We'll sign you up for the vets group. And if you came from the Reluctant Brotherhood, we'll sign you up for Men Speaking Freely as well, which is our version of the Reluctant Brotherhood meeting.
All right. Thanks, Alan.
Okay. The other thing is that it is standard of care, somatic testing.
Okay.
It's in the NCCN guidelines. You just need to tell your doctors that, and you need them to if your medical team is not getting it to you, are you dual registered?
What do you mean dual registered?
Are you with the VA and with private?
Yes.
Okay, so as long as you're with the VA, push it at the VA. Jim will help you, and you can get you. If the insurance is giving you a hard time, you can get somatic testing through the VA.
Okay.
So but your private insurance should be giving it to you because and your doctors need to. A lot of the times, the doctors don't want to do the work
Right.
to push it through, and you get it as often as they recommend it. It's not a once in a lifetime test.
Okay. That's good to know.
The cancer changes, so whatever you have today might be different. That's also true for Steve, who spoke earlier. We don't want to test your prostate from 6 years ago. What we need to test is something from right now, because the cancer moves and the cancer changes.
Adam, we say it so often here that sometimes we forget it. We just assume it's automatically understood, but we didn't raise it with you yet. Have you made changes to your diet and exercising?
Oh yeah. Well, so I've always exercised. So that, and I still do, and I did when I was in chemo and everything like that. I did stop some of the resistance exercises when I had the port in for the chemo because I was told to, which I think was a bad advice from the doc, honestly. But within a week of diagnosis, I completely changed my diet and went to, it's primarily plant-based. I'll eat fish, once or twice a week. Dr. Slovin at MSK asked that I would eat red meat at least some type of lean red meat about once a month. And so that's what I do. But, no alcohol. I've never smoked or done any tobacco products, so that was not a concern. But yeah, it's primarily plant-based. Lots of vegetables, no sugar, no processed sugar, gluten-free. And I've been doing that since diagnosis.
All right, very disciplined. I'm sure you're well ahead of most of us here. Keep it up.
Thanks. I think Peter had a question.
Yeah, let's see. Peter, did you have your hand up? Peter Kafka? Yes, you did.
Yeah, Adam, just curious. You might have mentioned, and I missed it. What led you to be diagnosed at 48? Was it a routine exam, or were you symptomatic? Did you have back pain, or was something going on?
Yeah, so I'll try to be as brief as I can with this. So in 17 or 18, right before I retired, I was noticing I was having to go to the bathroom a lot, and so they sent me to a urologist. And I did a test, and they determined that I just wasn't voiding completely from the blood. They just said, hey, sit on the toilet a little bit longer. And they did a digital rectal exam at that point, and they also did a PSA test, but I didn't know they did a PSA test. It wasn't discussed with me. And at that time, when I was 44 at this time, it was 2.5. Then they did another, I didn't know I was brought in, I think this was close to my annual physical. And so during my annual physical, they did another PSA test. Again, I didn't know it. And it was 2.8. And nothing was said. And then it was in my record, which I didn't see until I retired, but they said, check it in 6 months. Well, I was retired by the time they said, check it again. So I'd retired. I mentioned my problems with urinating to my primary care physician. He did not do a DRE. He just put me on Flomax. So I took Flomax for about a year, and then I couldn't really tell a difference, honestly. By that point, it really wasn't really voiding completely at all when I was standing to pee. I had to sit to pee. I had intermittent back pain, but nothing that was really, I work out a lot, so I just thought it was something related to that. Anyway, so a year later, he asks, hey, how's it going? I said, I really can't tell any difference. So he just said, just double the Flomax, and did not recommend me to a urologist or anything like that, and I didn't ask, nor did he do a DRE at the time. So symptoms continue to get worse, and about October, I would say October, November of 22, I really could only go to the bathroom sitting down. I started getting constipated more often. And then, like I said, in April, that's when I started getting the back pain. And I started getting a pain in my abdomen, which obviously was a lymph node. And so I told the doc, my primary care, and he's like, well, because I thought it was an appendix. And he said, we'll go to the emergency room. And so I was putting it off for about 2 weeks. And then Memorial Day weekend, I went for a run, and it was just really painful afterwards. My back was just killing me. And so I went to the emergency room at that point, and they did a PSA. Well, they did a CT because they were looking for the appendix, and they noticed how big the prostate was. And so at that point, they ordered a PSA. And the next day, they didn't have the results of it there. So the next day I called, and that's when they told me it was 570. And they said, you need to go see a urologist immediately.
Do you currently have urinary issues still?
No, not really. So like I pee standing up, no problem. I stopped taking Flomax about, I don't know, 2 months into after diagnosis. I don't take any of the medications I used to take. I used to take a lot of sinus meds, but since I changed my diet, I haven't had any sinus issues like I used to have. I don't have the back pain. Yeah, I don't take any medication.
Well, that's great. That's great because I know, I mean, including myself, you can get some kind of blockage with cancer. Yeah, interesting. Yeah, and
Yeah.
I mean, my sons are right on either side of you. One's 48, one's 50, and I wish they would be more proactive like you. But a lot of people don't, you keep getting pushed off. Good for you for moving on this.
Thanks.
Adam, are you aware we have an under 60 group?
No, I was not aware of that.
Yeah, for guys under 60. I guess Rick you want to comment on that, Rick, or send him to the website? What do we do?
No, when I sign you up, I'll include the vets group and I'll include the under 60s group. Right now, the under 60s group only meets once a month. The vets group only meets once a month, but it's hopefully going to twice a month before too long. But we'll sign you up for everything, Adam, and we'll be supporting you.
Thanks, Rick. I appreciate it. Yeah, I'm hoping to make this last as long as I can. So.
Well, you're doing well so far. You're responding very well. That's glad to see that.
Thanks.
So,
are your medical oncologists working together? Because my guess is that the guy that you have down in South Florida is not a GU medical oncologist, but is he working now hand in hand with Susan Slovin?
They were CCing Susan Slovin on everything. Finkelstein actually is a colleague from in the past with Dr. Slovin. And the original guy, Haberman and Finkelstein, were actually in the same office. But like I said, I've now switched to Haberman. I'm not seeing anymore. But all the doctors know of each other. So.
Okay, but you need a quarterback doctor, and in your situation, that quarterback doctor really should be the medical oncologist, the genitourinary medical oncologist. That's the person you should be taking all your guidance from and your instructions. Now, we can recommend other people closer to you. Probably closest to you it's a toss-up. It's either Houston or Miami.
Right. Yeah.
So you're probably about halfway between Houston and Miami, I'm guessing, where you are. But I think it's really, really important for you to have them as your lead doc, and whoever is your local doc implementing what they are recommending.
And that's what I wanted Slovin to do. But I mean, Slovin was like, well, look, I would want you to come up here. I wouldn't want to do Zooms. So I'd want to see you every time. And
Right.
so, why come up here to New York when you've got doctors down there, and I'm agreeing with what they're doing. So,
Right. So, we'd suggest you shift that whole relationship to either Houston or to Florida, where they will see you virtually.
okay.
You'll have to go in the first time, but they will see you virtually, and then you may have to find somebody locally to work with. But that's the problem with Memorial Sloan Kettering. Dr. Jack will attest to that.
Yeah.
And you don't need to be going back and forth. And Sloven's okay, but if you like her, I mean, we've had some people who love her and some people who don't like her that much because she's kind of cold.
She's direct. I mean, I'm a Navy guy.
But she's direct. Yeah,
Yeah.
she's direct. But we've got great docs in Miami. We got a great doc in Miami, and we got a great doc in Houston. Both of them are really good genitourinary medical oncologists. Both of them would see you after the first session virtually, I'm sure. I know the Houston doc would, and I'm almost certain the Florida doc would, because you're in Florida.
Yeah.
And that would be the best thing that we can suggest to navigate you.
Well, yeah, I would love and please send the names along. I'd appreciate it greatly. I'm assuming you're talking about MD Anderson in Houston.
No, I'm not actually.
Okay.
I'm talking about Houston Methodist, but the doc at MD Anderson was 14 years at Houston Methodist. Now we can send you to MD Anderson, but frankly, we think she's better than the MD Anderson genitourinary medical oncologist. But if you want to go to MD Anderson, we can give you a couple of names there.
No, I'd be open to the names that you would recommend. I don't care that it's MD. I was making an assumption.
No, right. No, I mean, it's a very reasonable assumption, and we've worked with a bunch of people at MD Anderson, and they're good, but we think she's better. And there are a bunch of guys in here who have gone there. She left about 2 years ago to start up a GU medical oncology group at Houston Methodist. So I'll send you the links. The Houston Methodist doc is Dr. Eleni Evstathiou. I'll send it to you momentarily.
Okay.
And the doc that we would recommend at Sylvester in Miami is Dr. Mario Bilusic, Bilusic. And we'll send you information on both of them, and you can talk to guys on this call who are seeing them.
Thank you.
All right, Adam. Hope you'll come back and keep us posted on the decisions you've made and how you're doing, okay?
Definitely. Thank you very much, Lynn.
Thank you. So now let's get to our regular crew here. We'll start with Julian Morales. Go ahead, Julian.
I had to unmute myself. Yeah, I got an appointment coming up with Dr. Elena Stasio on Thursday. We did do some blood work. My PSA is 0.0, but the total ultrasensitive is 0.014. So that's a tick there. So I'll talk to her about that. But my testosterone is still low. It's at 107. So it's not progressing slowly upward, but not as fast as I'd want it. That's about it.
So you're on a drug holiday at the moment, Julian?
Oh yeah, I've been on a drug holiday for over a year.
Okay. And I forgot, how old are you?
I'm 72.
72. And how long were you on hormone therapy?
For about a year and a half.
Okay, well.
I was on Orgovix and Nubeca.
Yeah. Well, I don't know. Everybody's different. It may come back. It seems to be coming back awfully slow, but.
Yeah, I'd rather slow than fast.
Well, now, as long as you're feeling okay.
Thursday.
All right. So anything else for us, Julian, or was that just an update?
That was just an update.
I wouldn't worry too much about the 0.014. I'd be pretty happy with that.
Well, I have two. I just see what Dr.
Yeah.
Easton wants to do next, or just keeps monitoring me. She's doing a great job.
Okay, very good. Uh, Don Rogers, you needed time tonight?
Yeah, just a quick update. I had a Zoom meeting this morning with Dr. Belusic at Sylvester. We're going to stop the Eligard after 2 years. We're going to stop the abiraterone in June, taper off the prednisone, and see what happens then. I've been on the ADT for 2 years, and I'm thrilled. I'm going to have a holiday.
All right, good for you.
So, a question, Don. Did you say you did that with him virtually?
Yes, I live about 42 miles away. And the
Right,
initial
right.
meeting, I asked him if we could just meet virtually. He says, "Sure, fine."
Okay, that's good. So there you go, Adam. So, Belusic will meet with you virtually, and Dr. E will definitely meet with you virtually. So we can confirm that for you, Adam.
Thanks. Yeah, I think I have more places to stay in Houston, so probably lean toward that. But I'll do my research also on both of them. What you send me
Okay.
information.
I'm just trying to do a bunch of things, but I'll get these links to you right now. I'll put them in the general chat in case anybody else wants to check out these doctors too.
Okay, Dr. Jack, you are up.
Okay. Talking of Dr. Belusic, I just saw him the other day. He's wonderful as usual. And he, I wanted to give you some information he gave me, which is very, I asked if Sylvester had a cardio-oncologist, and unfortunately they don't, but because I'm dealing with some issues with my heart as it reacts to the medication, and very few cardiologists know how to handle that. But for those in the Washington, D.C. area, he recommended Belusic because he spent time at NIH. He recommended an Anna Barack, B-A-R-A-C, at Innova in Georgetown, and she's a real professional when it comes to cardio-oncology, and I may do a virtual with her. So if that's information for those who live in that area who may want to contact her, Anna, B-A-R-A-C. Also, I had some good news. After 1 year of being on darolutamide and 10 months on ADT, Orgovyx, my CBC came back. It's recovering. My absolute neutrophils came up. My hemoglobin and platelets came up, and I was kind of thrilled. I didn't know, I wasn't sure the CBC was accurate because I've been having a bronchitis and bad cold for the past 4 weeks since I was in New York, and I thought maybe the white count went up because of the infection. But since the hemoglobin went up and the platelets went up and everything else went up, I think it's just recovery. And as Dr. Belusic said, don't worry, the Nubequa, the darolutamide will make a comeback, and it's not going to stay down permanently. So again, he came through with his assumption. The other thing is today is my 21st anniversary of my prostatectomy at Sloan Kettering, and so it's to the date 21 years ago. So it's interesting. And otherwise, I had a great lunch the other day with Paul Frieda, and Don Rogers, Al Latimer, and David. Thank you, David Muslim, for setting it up in Fort Lauderdale. Really enjoyed meeting you guys and hanging out with you and having lunch. It was a pleasure.
Nice photograph.
Thank you.
Yeah, that was a great get together.
It really was.
So, Jack, what is your H&H now?
My hemoglobin?
Yeah, and
Uh,
hematocrit.
13.9.
Oh, that's great.
It used to be 15.5, 16, but I'm pleased. It went from 13 to 13.9. Absolute neutrophils are up to 2.8, which is great, and my white count is 4,200 rather than 3,000. So it's a big jump. Platelets are up, everything's up. PSA undetectable. So
Terrific.
Enjoy.
And congrats on your 21st anniversary. You're still with us.
Yes, that's right. Thank you.
Okay, thanks for the update. Let's see, who have I got? Gary Peters, you had an update for us or a question.
Yes, let me. Um, I've read a couple of things in the last week that I'd like to direct to somebody in the Brain Trust, but I'm just wondering, preliminarily, have any of you ever heard of some research that says while glucocorticoids are carcinogenic in the short term and helpful in combating cancer, over the long term, they can promote resistance?
Well, Dr. Jeff, you want to chime in?
Well, if you're on a drug like abiraterone, you don't have much of a choice unless you want to risk raising your aldosterone and becoming fluid overloaded and sodium overloaded, hypokalemic. You really, if you're taking a drug that's going to block your glucocorticosteroids, cortisone, you really need to take prednisone or prednisolone. It would be a big gamble if that's what you're referring to, not to take it while you're on a drug that blocks your natural cortisone. But is it true that the longer you take it, you gradually increase the likelihood of resistance? That I'm not familiar with. If you could put the article in the chat, I would love to read it.
Resistance
Yeah,
to
I'll try to get it in the chat before we close. If not, I'll definitely put it in next week. Right.
steroids, prednisone and cortisol are immunosuppressive, and you take it over a long period of time, your immune system is not going to function as well. And although it's anti-inflammatory and it does a lot of good things, but over the long term, your immune system gets suppressed by steroids like cortisol or methylprednisolone or prednisone. I think.
Yeah, and they give steroids with chemotherapy all the time, right? I mean, it's
Short
uh,
term, not long term.
short term, yeah. But that was his question. Is it cancer promoting in the short term? I don't think I've never heard that.
No, not in the short term. I know it's not in the short term. My
Oh, okay.
question pertained to the long term.
Okay.
And since my adrenals did not recover after I stopped the prednisone, I'm now on another glucocorticoid, hydrocortisone, and I don't know when, if at all, I'm going to be able to stop that.
Well, it's just replacing your non-functioning adrenals. So I mean, it's not like it's extra glucocorticoid hormones, right? So you'd have more problems if you stopped it, I would imagine.
Well, I'd certainly have short-term problems. Yeah.
Yeah.
Okay, well, I'll get those in the chat either tonight or next time, and be interested in what smarter people than me think of it.
Okay. Graham, are you still with us, Graham?
Yes, I am. Yeah, I'm here.
Okay. And are you new?
Yeah, and I'm not entirely sure if this is the group for me, but let me tell you where I'm at.
Okay.
So last year, I got a biopsy done in October, and that came up with Gleason score 4 + 3 = 7, 60% overall pattern, 10 out of 10 sites involved, 12 out of 12 cores. Overall tissue involvement was 56%. My PSA was 17, and I just did it recently, and the PSA's jumped up to about 30. I did a bone scan a few days ago, came up okay, and also a CT scan that came up okay. So next, in 10 days, they're asking me to come up with a decision whether I want to do the prostatectomy or whether I want to do radiation and a I forget what they call it, a brachy or something like that.
Brachytherapy. It's a type of
And
radiation.
yeah, and I guess the kind of androgen type therapy kind of thing.
Yeah, the hormonal therapy.
Yeah, hormonal therapy. That's it. Yeah.
So, I'm sorry, what were the results of your scan? Did it show any lesions outside the prostate?
Nothing outside of it.
Yeah, so that's a tough decision, whether to go with surgery or radiation.
Yeah, let me add that I'm single and I don't always want to be single. And I've already put it off for 2 months just getting those tests, because those tests trigger the doctor appointment to decide what to do.
Yeah.
How old are you?
I'm just turning 63.
Well,
It sounds like you're Canadian, is that right?
That's right.
Yeah. And you're based in Canada?
Yeah, I went to the Ottawa
Okay.
General Hospital for the testing.
So the first thing that you need to do, this is a pertinent conversation because we've been talking a lot since last week amongst ourselves about Francis Collins, the director of the NIH. And this is something he did, I would guess he did not do. And the first thing that we recommend you do if you're high risk, because you are high risk with a PSA of 30, even though your Gleason is still showing 4 + 3. Have you had those slides reread?
That was last October, and I haven't had a biopsy done since.
Okay, well, you need those slides reread because it's going to impact on the amount of hormone therapy that you get. So
Okay.
you need to send those slides off. Somebody can put perhaps if somebody would please put in the chat window, either for Dr. Zhu or for Johns Hopkins. It's probably going to cost you about $300 out of pocket, but you really should get those slides. If it were me, I would get those slides reread because it can be important for you. Now, what you need to do is run the Memorial Sloan Kettering nomogram, the pre-radical prostatectomy Memorial Sloan Kettering nomogram. And the reason you need to run that is it's going to tell you how likely surgery alone is going to solve your problem. So the first step, and before you start making decisions as to which way you want to go, is to have your slides reread. Once you get that confirmation back, you run the Memorial Sloan Kettering nomogram. Do you know what nomograms are?
No idea.
They are a database of a whole bunch of people, and they're usually collected by institutions like maybe Memorial Sloan Kettering or the Parton tables at Johns Hopkins. UCSF has one, and they compare people with the same disease demographics as you to see what their outcomes were. So it doesn't necessarily mean it's true for you. What it does mean is it's a really good guideline. So you go to this site. I'll put it in the chat window. I'm just trying to look it up as I'm speaking. So you go to this site and you put in all of your information for the MSKCC one. You'll have to put in how many cores were positive. In your case, it was 100%, and your Gleason, and your PSA, and your age, and it will tell you how likely it is that surgery alone is going to be successful. And my guess is, in your case, you're probably going to be faced with it, just from what I know, probably an 80% or maybe even higher likelihood that it won't be successful. So you've got a 20% chance that surgery alone will do the job.
What the surgeon said was that they take the prostate once it's out and they examine it. And I
That's
think
right.
if there's
That's
something,
right,
I think
Graham.
yeah.
Graham, hold on. That doesn't help you
Okay.
now. You need to know your Gleason score now, because that's going to influence whether you want to do the surgery or whether you want to do the radiation and hormone therapy.
Okay, so you're suggesting I do another biopsy?
No, you don't have to necessarily do that, but send those last biopsy slides to be reread.
Okay.
Because if you are a 4+4, if another, here's the thing with reading genitourinary biopsy slides, it's very specialized. And so you want the best eye you can to look at those slides. And the likelihood is that at Ottawa General, they just had a general pathologist review them. And so you've got to confirm that 4+3.
Okay.
Now, if it's a 4+4, they're going to give you more hormone therapy than if it's a 4+3. So it becomes really important. If in fact you're a 4+4 and your slides have been read as a 4+3, they're going to stop the hormone therapy after probably 6 to 8 months. And then you're going to wonder, why did my disease come back? Well,
yeah, the radiologist was saying it was either 16 or 18 months. And I don't know what they were going to use.
Okay, well, 18 months is probably right. And maybe they're basing that on your hormones. They're basing that on your Gleason, on your PSA of 30.
No, they haven't. They don't have that yet. So that was on my previous score of 17.
Okay, and you're sure that all of you were only a 4+3.
Yeah. Yeah, they're all 4+3.
Okay, well,
Go
ahead.
The one thing that the surgeon did say was that my prostate is small, and when I looked online to see what size a prostate is, typically it's smaller than a typical small size.
So
Which
is
I
it
think
about 20? It's about 20
Um,
cc's. How many cc's is it?
uh, um, yeah, I have that somewhere, but if I can find that quick. Just go ahead if you have something else to say, and I might
No,
say,
well, I mean, I can relate it to myself. My
yeah,
prostate was about 20 cc's, and I was a 4+4. And very often, the smaller the prostate, the more aggressive is the disease.
okay.
So, I mean, if they're already treating you as if you're high risk, maybe you don't need to get maybe you don't need to get the slides reread, although I think I would probably have them reread. You're going to want to know if you were a 4+4 or 4+5 down the road. And Peter's put the address for Dr. Zhu in the chat window, and he's put the address now for Hopkins. And
Okay.
I would say it's money well spent.
Okay,
But
I found the size of my prostate. It says 23 mil volume.
right, it's 23 cc's. Well, that
Okay.
was, I think that's what mine was. I think mine was 21. So, but I think the most important thing for you to do right now to make a decision is to confirm your Gleason score, and then you just go online. You can do it now, and you can do it again when you confirm it. Here's the MSKCC nomogram. You can bring it up whilst we're speaking. Even I'm just going to put it in here right now, and you'll run these. You'll run the numbers, and whoops, that only went
Okay.
to Len. Sorry, you'll run the numbers and you'll see, and it'll tell you. I mean, I actually wrote to Francis Collins today and urged him to run those numbers. I mean, he's under the misconception that surgery is going to cure him. So, with a 4+5, surgery certainly ain't going to cure him. So you've got to wonder where he's getting that information. And to me, I used it myself. This is how I decided originally to do brachytherapy and not to do surgery. And I was diagnosed at 56. So because I really didn't want to deal with a whole lot of extra side effects from the surgery, because the upside from doing the surgery on top of everything else is minimal. Maybe you get about another 3% out of it. That's what probably the best urologist in the country estimates. So there's the nomogram, and if you click on that and you put in your numbers, you'll find out how likely it is that surgery alone is going to be successful. If it isn't going to be successful, you're going to be faced with radiation and hormone therapy anyway. So then you have to decide, well, do I want to put myself through the surgery if I pretty much know I'm going to have to do hormone therapy and surgery? I mean, you might have a 20-25% chance. In Francis Collins' case, he's got a 5. I'm guessing from the numbers that he's given us that he's a 4+5, and he's got a PSA at 22, and I'm figuring half of his cores are positive. He's got a 5% chance that he isn't going to go through radiation and hormone therapy. And I bet dollars to donuts he hasn't figured that out, because anybody in their right mind wouldn't do that.
How quickly do I need to move on this?
Well, when I got diagnosed as a 4+4, my doc gave me 4 months to make a decision. He said, I got diagnosed in the August, and he said, I really want you to make a decision by the end of the year. And I actually made the decision and started my hormone therapy towards the end of November. And I think he was a great doc. he was a urologist, so he didn't actually treat me. He followed me, but he didn't actually treat me.
Graham, you
Well, I
said your
can't say.
PSA went from 17 to 30.
Yeah,
And what period of time was that?
that was from uh, that was from June. Let's say July 1st to March 30th.
Oh, that's not bad.
9 months. Yeah.
Yeah, you see that also troubles me, because if you've got a PSA of 17, whoever's following you shouldn't be allowing you to go 9 months without a PSA.
Oh, but I delayed things for 2 months on my own by I just didn't want to think about it. Just relax and.
They shouldn't have allowed you to go more than 3 months without a PSA, if that.
Well, as soon as I saw the radiation oncologist, that was like that was in January. He was like ordered a PSA, but I put it off.
Okay.
Don't do that.
Jimmy Greenfield, go ahead.
Yes. Hi, Graham. My personal experience is that I had a 4+3, and the surgeon told me that my odds of success were equal with surgery or radiation. Had I taken him, I took him at his word, and I chose surgery. But it's very popular for the layman to choose surgery because of the appeal of getting it all out, so to speak. But many surgeons are kind of zealous, and they will say that we'll get it all out, and I often don't. But what's important in my case is that I chose the surgery. I ended up needing radiation anyway. Ended up needing hormone therapy anyway. But most importantly, you started out by saying something I caught when you first spoke. You said you were single and you didn't want to remain that way. Did you say that?
That's right.
Does that indicate to me that you are concerned about sexual side effects?
Yeah.
Okay, so one thing I can tell you from my personal experience is that the prostatectomy, in my case, and it is not uncommon, they warned me of it, that the chances of chronic erectile dysfunction are very high. And of course, they exist with radiation too, but statistically, your odds of regaining sexual function are better with radiation than surgery. And it's a tough row to hoe if you have to be on hormone therapy, because it takes away your libido, and you have to work at maintaining, they'll tell you all this. You have to work at maintaining your sexual function, at least physically, while you're on it, even if you have no desire. If it really means that much to you, and I understand that it does, I would think hard about surgery, because I had all of the assurances in the world that the nerve bundles on each side of the prostate would be spared in the surgery. And I've talked to more people than I can count, and read about more people than I can count that had surgery for which that was not the case. And I'm only
If I
telling you
have
about myself.
so I would just, since I have a small prostate, does that make it even more difficult to
There's
have
no
a good
way
outcome?
for me to know anything about that.
Yeah.
All I can say is that surgery is at the very least risky business when it comes to preserving your sexual function. I don't think anybody
Okay.
would dispute that.
Now,
So
after
radiation can be too, but
yeah.
dollars for dollars, radiation gives you a better chance.
The small prostate makes you a good candidate for either surgery or radiation.
Yeah.
Okay. Now, the nurse said something that I don't remember the radiologist saying, was that she said that if you choose radiation, you can't do the surgery after.
No. That's not true anymore, and the nurses need to go back to school and figure that one out. I mean,
Although
just to put it
remember that you're
bluntly, they love to say that. It ain't true. It might have been true 15 years ago, but it's not true today. Peter Kafka, did you want to say something?
I said, just keep in mind that you're in Canada. You don't have the same number of experienced doctors in either field, or maybe the same equipment in either place. You're in Ottawa, yes, or someplace up
Yeah.
there? Yeah. I mean,
The
I
the
would
um
hunt.
the
I would hunt
surgery.
around.
Just let me interrupt for 1 second. It's laparoscopic. I know that if they did the surgery.
Right. That doesn't mean it's foolproof. I mean,
Okay.
that's pretty much all they're doing now. But it's the experience of the doctor. It's not the robot that's experienced. It's the doctor, and whether it's radiation and the kind of how new and what kind of machinery they have for radiation and what kind of experience the doctors have.
Yeah,
Canada is very different than the
I
United
think my
States.
I think my doctor's had a fair bit of experience. He's been around for a while, and he said he only ever had one issue during surgery earlier in his career.
I don't believe that. I don't believe that. Even the most experienced doctors I've known, I mean, things can go sideways, and it's not necessarily the doctor's fault. I mean, we're all very different in different ways.
I want to say one more thing. They told me the exact same thing. When the surgeon told me that they can't do surgery if they do radiation, they can't do surgery after that. That was in 2019 at a major center of excellence in the United States of America. And I would say there's no question that some surgeons, many surgeons and their associates will use that as a selling point for surgery. And it's not right.
Yeah.
Okay.
And let me just follow up something too. And Jimmy said, and I agree with him. I also had prostatectomy and radiation, and my spontaneous sexual function, yeah, it was gone and it's still gone. But there's ways to treat that erectile dysfunction. I happen to use the injection method, and it's working like wonderful for me. Now, it's not true for everybody, but don't think it's you're gonna have that problem whichever way you go. But you can recover from it, and the docs do have ways to treat that.
And the consensus here is that radiation is the least harmful to your erectile things.
Not necessarily.
Well,
That's my opinion.
Look, it depends on whether they can spare your nerves or not. From the sound of your diagnosis, I doubt that they could spare both sides. They may be able to spare one side, just from what you're telling us, especially with 10 plus 10 cores. If you have radiation, you're still going to have sexual side effects, but they're going to occur over a much longer period of time. And there are things you can do, but what I think is happening right now, Graham, is that you might be being sold a bill of goods by the surgeon. I can't talk about the radiation oncologist. And brachytherapy plus IMRT to the pelvic girdle plus hormone therapy is probably the gold standard for a high risk diagnosis. Not probably, it is the gold standard. So you have to make the decision, and if you run that nomogram that we put the link into, it's going to give you a good idea as to whether the surgery alone is going to be sufficient for you or not. In my own case, my numbers came out 30%, that the surgery alone had a 30% chance of success, and I didn't want to roll the dice on 30%. But only you can make that decision. If you want to keep hearing, how did you hear about us? How did you find us?
I managed to hit up a Canada group, and they were the watch and wait group, and they said, like, try the US group. So the leader of that recommended.
Okay, so send me your chat, your email address, or put it in the chat. Oh, you're on the telephone. Okay.
No, I did set it up when I can put it in, but when I logged in, I did put it in there.
Okay, then we'll get it in there, or put it in the chat window anyway, and we'll sign you up so you get the reminders before every meeting, and we'll sign you up for the Men Speaking Freely group, and we'll continue to support you. But I mean, the best advice I can give you is to run that nomogram so you know how likely it is that you might need radiation therapy and hormone therapy anyway.
And Graham, if you're on the telephone, my email is Peter K, Peterk at ancan.org,
No.
and I'll send me an email and I'll send you the
I
second
put my
opinions on
I put my
pathology.
email in the chat.
Yep.
Got it.
Okay.
We have it.
Okay,
he
so
might
if you
do
could just
well
email,
in he might do well in
if
your
you could,
group, Peter, where he gets
Yeah,
to.
I know. Yeah,
Yeah.
next Monday we have the low and intermediate group with a lot of guys trying to figure out whether to do surgery or radiation. It's a good conversation.
yeah,
But
can
you
you?
might, yeah, but you also, I'll
I'm
try
having
to
a bit of
email you.
problems hearing, so if you could email me since you have mine,
I don't see it. I'm sorry.
it's at the
It's
should be at
in
the
the
very
chat
bottom.
window, Peter,
I'm looking.
right at the bottom.
Oh, I see it. Okay.
And you'll get reminders to both meetings, Graham, and hopefully by by Monday you'll have run that nomogram. And like I say, I don't know, Peter, would you send your slides out in a situation like this or not?
I'd always send my slides out. It's cheap and it's expert. I don't trust Canadian medicine.
Okay, Graham, we're going to need to move on. Dr. Jeff, you are up.
Yeah, a question and a comment. The question is a couple of
You're muted.
Yeah, a question and a comment. So the question is, very recently, you guys sent out an email giving us the option to do questionnaires with Amanda Wills pinpoint patient recruiting, and I think you're supposed to get paid for it. I just want to let you know I did it, so I hope you got paid for it.
Okay, so I was in touch with her last week. She said that the checks, they were sending out the checks. They were sending out the personal checks and they were cutting the checks to us as well. So hopefully you've gotten paid. If you
I
don't
did.
get paid by next week, Dr. Jeff,
No,
let me know.
I did.
Oh, you did. Okay.
Yeah. I want to
Thank
make
you.
sure
Yes.
you got paid.
Appreciate it. Yeah, we had 18 people who responded, so it'll make a nice donation to AnCan, and thank you very much for responding.
Good. My comment is that I think everybody is well aware that men in their 70s can have normal testosterones. I'm not talking about men with cancer and on therapy, but can have normal testosterones and still have decreased libido, decreased ability to get an erection, maintain an erection, because there's a whole bunch of other things that go into it, psychological things, arteriosclerotic things, hypertension, diabetes. So, getting one's testosterone back into a range you want doesn't guarantee that everything's going to be fine. But as you heard, there are other ways to get erections, like there are implants that can be done, semi-rigid implants, implants that you can control by pumping them up and down. And if the purpose of it is to have intercourse, you can have a zero testosterone and have an implant after surgery, after suppressive therapies, and have penetrative intercourse. So it's not necessarily you got to get your testosterone up and take testosterone therapy. There are other avenues.
Yeah.
Okay, Dr. Jeff, thank you for that. And
No, I think I'm real glad that you made that point, Dr. Jeff, because I think people hone in on the testosterone levels because they want to be just like they were before. And I think one of the problems that men who get diagnosed with prostate cancer, whatever the level, even active surveillance where they haven't had the treatment, is once they get diagnosed, things ain't going to be the same as they were before. And for some of us, it may be issues around erectile function, it may be around incontinence, it may be around bowels, it may just be around anxiety, which is a very, very significant issue for men on pre-treatment active surveillance. It's unbelievable. I mean, we don't think about it much here because it doesn't seem to be that a big deal for us, but for those guys it is. And if you attend their groups, you hear it. So whatever it is, there's always, you don't get off scot-free. And I'm really grateful that you said what you did. Thank you.
Rick, I'm getting a message. It says
Me
someone is
too.
waiting. Oh, what do we do with that?
I have no idea.
Okay. All right. So just a few more guys. Gao Shan, are you still with us?
Yep, I'm here. Yeah, I had a bunch of blood tests taken on Saturday this past weekend. And just to give a quick overview, I had 32 sessions of IMRT from May of 21, and I had 27 injections of 22.5 milligrams of Eligard. I've now been off of, or call it a drug holiday now, for almost 17 months. After I got off the drug holiday, my PSA for the first year was 0.000. And late last year, it went to 0.001, which was the same as it was in January of this year. And the most recent test I just got today after meeting with my Panama GU Medoc was 0.002. So, I mean, it's way low. But the good thing is my testosterone has gone all the way up to 406. But my PSA is staying very low. So at this point, even though I know it's a long road that we're going to go on, right now I'm in good position with low PSA and higher testosterone. I had a radical prostatectomy 11 years ago, and this morning was the first morning in 11 years I woke up with wood.
All right.
So that was quite surprising, to tell you the truth. I had a whole bunch of other blood tests, and all my blood tests were in the normal range. The only part of my blood test that was high is this thing I'm dealing with my LDH. It started out at 158 and went all the way to 323 in January of this year, so it's off the chart. But the most recent test, it brought it back down to 298. So the doctor said, okay, well, let's do blood test every 45 days and see where it is. If it continues to fall, that's good. If not, we may need to look at some other options.
So Gauchan, what was your doctor's comment on why your LDH took off all of a sudden?
Well, I mean, if I can go into a little bit, I've had a mole between my belly button and my pubic area for 50 years. And I didn't even think about it when I went through the radiation. That mole was always quite round and the whole bit, and nice brown color, not dark or anything. And that mole would have been in all 32 of those IMRT things. Now, the radiologist says, oh, it's not likely. But, I mean, who knows? I mean, I never had an issue. And then I noticed in in January of 2022 that it had changed shape. So I went to the dermatologist. They cut out a bunch of tissue, like 20 millimeters all around, and did a biopsy, and it came back as melanoma. Then went to see another surgeon, some other thing, had a bigger surgery, and also went down and looked at all the lymph nodes. And the way they test it is how deep it is, how wide it is, how aggressive it is. And I was all at the right under the first level of of not being bad. And but he told me you need to have your LDH tested now, and then every year do it again. And the first two tests were below the level, but when I came back to Panama in January, it was 268, and a month later it was 323. So they said, well, you also need to go get a PET CT FDG scan because we need to make sure that it's not melanoma. And they did that, and they had two different doctors, two different places, major hospitals in Panama review the scans, and there was nothing found, all negative. Uh, so they basically said if it still stays high above the level, they said that there's a place that does blood tests for this LDH that can be more specific where what organ in your body it may be coming from or whatever. So that's kind of where I'm at. I mean, I never would have thought you'd get melanoma between your belly button and your pubic hair, but it may have been caused by the radiation.
Yeah, that's interesting. Well, let's focus on the good stuff, which is that your T levels are high and your PSA is very low.
Yeah, so it's been since July of 22 until end of December. I think it was December of 23 that it was basically 0.000 three zeros, and it was only at the last end of December when I got the test that it had gone to 0.001. Now, all the countries I go to, like Panama, Taiwan, China, they always go out 3 digits, and I know what Rick's point was. Don't have them go that low, because if you go, I went from 0.00, that's a doubling in X amount of time, but you just deal with it. It's not, it's still undetectable, but it's just the way they test here.
Okay, Sean, we're going to move on. We got two more fellas, John Kish and then Eric. Go ahead,
Thank
John.
you.
Yep. John, are you still with us? Maybe not. Anybody know who caller number 4 is? Okay. Eric, are you with us? Can anybody hear me?
Yes.
Oh,
Hear
you
you
can.
loud and clear,
Okay.
Lynn.
I hear you.
Okay, so Eric and John Kish are both missing in action. Going once, twice, 3 times. I think we're ready to close it down, guys.
Good job, Len. Good
Yeah, we
job.
got 4 new guys in. How about that? It's only 16 after the hour.
Thank
So
you.
thank
Good.
you
Good
all
job.
for your participation. We'll see you next week.
Great
Good
job.
night.
Thank you,
Good
Len.
night.
Good night.
Good night.